Lovely. And thank you for taking the time out of your busy day to come along today. For those of you who don't know me, I'm Lisa Harrod-Rothwell. I'm a London GP and CEO of Londonwide LMCs. And I'm delighted to be joined today by my team of experts across a range of key areas, including practice funding, contracting, and commissioning. Today is about clarifying the contract changes and creating space for your questions and concerns. I hope this will be the first of many webinars to come, but as this is our first one, please do bear with us with any technical glitches, which in my case may be more likely to be user error, as I demonstrated in the trial run. I want to start by grounding us in the role of LMCs, local medical committees, and London-wide LMCs, because that really matters in the context of today's conversation. We are the representative bodies for general practice, recognised in statute. At the heart of everything we do is one simple mission: to value, care for, and protect GPs, your teams, and your practices. And we do that in three main ways. We represent you by making sure your voice is heard at borough, ICS, and London levels. We advocate for you, for example, by challenging national decisions and policies that impact negatively. And we provide tailored services, such as guidance tools and bespoke advice. What we don't do is negotiate the GMS contract, and we're not here to defend it. But we can help you understand what's changing and what this means for you and your teams. Today, we'll be covering GP funding, changes to QOF, VACs and IMS, direct enhanced services, and the impact of contract changes on ways of working. We'll be sharing all of our slides after the webinar. We also hope to answer as many of your questions as time allows. If you go to the Q&A tab, you should see an Ask a Question box at the top on the right-hand side, but it will depend on your device and settings. Don't worry if we don't answer your question today. We will be collating them all and we'll send you a Q&A. It's also important to be aware that there are still a number of unknowns. If we don't have the answer, we'll pose the question to the people who should on your behalf. We also want to hear your views on the anticipated impact and your concerns so that we can advocate for you in political and policy arenas. But with no further ado, let's start by exploring the funding, and I invite Asia to the virtual stage.
Hi everyone, I'm Asia, one of the medical directors here at Londonwide. I think I've already made a slight mix up there. Here we are, right, there we are. I think we can all see the funding. Great. So in the next 10 minutes, you're going to get an insight into the GP contract finances for this year, the headlines, are there any gains, what the transfers, losses, where there have been any changes or no changes, and what that really means for you in terms of global sum per patient. So the headline contract numbers, you will have seen the letter from Amanda Doyle, who's the National Clinical Director of Primary Care and Community Services, that was released in the latter part of February of this year, which really demonstrated that there is a £485 million funding increase overall, which includes £69 million into the DES, representing, as her letter stated, a 3.6% cash increase. And that's before inflation is taken into account. But when inflation is taken into account, that's 1.4% real terms growth, bringing the total value of the contract to £13.863 billion. So that sounds like a lot of money, doesn't it? But let's actually break that up. What does that really mean when we take it apart? So 416 million of that global sum itself is pertaining to a £260 million uplift, and we'll look at that in a little bit more detail, the effects of inflation and the DDRB assumptions around that uplift. 121 million of that is for list growth pressures, 25 million for additional QOF money. I mean, it did say circa in Amanda's letter, for 18 new indicators, which you'll get an insight about later, and £11 million in into the Statement of Financial Entitlement, the SFE, for local reimbursement. So that's your 416 into global sum, and 69 million goes into the PCN DES. 53 million of that is the ARRS salary uplift alone. But this is still good, isn't it? I mean, you can think, well, actually, that on the surface of it sounds great. Well, you're going to learn, and we're going to talk through, actually, is it good enough? So where does that leave us? And I just want to really highlight an article that was published about a few weeks ago in the Health Service Journal. Some of you may be familiar with this journal. It's a journal particularly for hospital managers, and does on occasion touch on general practice spend. Now, this article highlighted three critical things, really: that the share of funding for general practice is falling. And if you look at this chart here on the right, the blue areas here, so if we look at it, actually, it's based on sector. So you've got specialised services, and this is here. I hope you can see my cursor is primary care, and I want you to look at primary care, general practice, i.e., and here the acutes. And this is the percentage of total NHS spend, and that's based on the accounts for NHS England. In general practice, we have 8.3% of the total share, and that's at its lowest since 2015. Only 5 years ago, in the peak of the pandemic, that total spend was 9.2%. But interestingly here, when you look at the acute spend, it's actually increased by 4% of the budget in comparison to the last decade. So that's somewhat worrying, given that general practice delivers 90% of activity within the NHS for only now 8.3% of the funding. And the other thing to note in this article is that the proportion of NHS doctors who are GPs is at a decade-long low point, at 15% of the workforce. When compared to 2015, that was 21%. So we are in a bit of a crisis here. I want to now spend some time just looking very briefly at that inflationary uplift that we referred to earlier. So Amanda's Doyle's letter really looks at the inflationary uplift relative to the GDP deflator. And we have looked and just taken that apart a little bit to see, well, how is this calculated? The GDP deflator is a measure of the economy-wide inflation. It covers all goods and services produced in the UK, including government services and investment. But the real-world practice expense costs that we see more closely track the CPI, the Consumer Price Index tool, and that really reflects a fixed basket of goods and services. It captures rises in utilities, estates and costs, and day-to-day operating expenses, and it takes into account cost of living, which the GDP doesn't. It doesn't cover staff, but the DDRB and the Agenda for Change, the AFC, cover that later, and we'll look at that. So the GDP deflator almost always underestimates the real-world cost pressures that are faced by general practice, often by significant sums. And this is what's been used in the contract that's been presented to us. So if we look at that and dig deeper a little bit here around what does that mean for the numbers. So the uplift using the GDP deflator was 260 million. But if the CPI had been used, which takes into account the cost of living, the uplift would have been closer to 428 million pounds. So that gives you a deficit of 168 million pounds that should have gone into the contract that actually isn't in the contract. So if we accept that the real world rise in cost is actually 428 and not the 260 uplift in the that's been presented, the real term growth actually is only 0.26%, not the 1.4% claimed by the Department of Health and Social Care. And that's really supposedly there to pay for all the extra workload, which you'll hear about in the rest of these slides around the contract. This really here is just if you want to play around with it a little bit to understand the Bank of England inflation calculator, and you can look at this to look at how the costs increase year on year, and you can play around and tap into that should you wish. So I'm going to spend some time now looking at the transfers of what's actually gone into the contract. So there's been a lot of money moving around. Effectively, the government have taken a significant sum of money, that's £292 million from the PCN DES, and put it into core, but with strings attached. This is not new money, and if people were already receiving this and using it to fund the running costs of other staff, it's actually going to leave them in a sticky position, as it can now only be used to fund extra GP sessions. What this means in practice, we still don't yet know, as the contract details are yet to be published. But what we do understand that this £292 million was originally intended to support the formation of new neighbourhoods, but that was then diverted back into practices with other strings attached. So that's just important to note there. And then the £82 million has also been moved into core from the Retired Advice and Guidance Scheme. What's important to recognise here, that this scheme is planned for a massive scope in the next year. There's going to be a huge extension to it, and there's no new funding attached. So what that means in practice, and what we'll start hearing, we can just imagine, is that this will become expected for us to do because it's in the core funding. So we need to recognise that while that sounds great on paper, actually there's more to come in relation to what the expectations are for general practice. Losses, very little, a very small amount has disappeared from QOF, and a large amount has been added, the 18 indicators. £7 million has been lost from the Retired Weight Management Enhanced Service, though there are some new QOF points for weight management. And what does the global sum consist of? So I just want to spend some time trying to understand, well, when we talk about the global sum, what does it actually mean? So it's supposed to consist of three parts. The first being the contractor partner pay at 31%, the staff costs at 53%. But important to note here that a BMA survey last year only suggested that the real figure of staffing was actually closer to 72% than the 53% of global sum. And then other expenses. It's clear that global sum no longer really truly covers the cost of practices, and that's what we hear certainly within our LMCs from the practices on the ground. We're dependent on QOF, we're dependent on quite a lot of PCN DES income and discretionary incomes where they still exist, such as locally commissioned services, to enable us to function. The government uses that 53%, which I've touched on, but it might be worth checking your own percentage of staff costs over global sum. And if your staff percentage costs are lower than 50%, 53%, you gain slightly more than the headline numbers. If higher, you will lose out. So that's just worth for you to test out your positioning on that. So what does this really mean for you? That these are now new numbers, given that the DDRB agreement has been agreed by the government of 3.5%. So this will now increase the global sum per patient of £130.07. And there's an uplift of £6.73 or 5.5%. But it's really important to note here that this remains unweighted, as Car Hill has not yet been applied. And within the London region, assuming most of the GPs and practice members here are London practices, that there's an additional £2.18 per patient if a patient's registered within the GLA, the Greater London Authority. Just want to say that if you're going to think about one slide and one thing to really go away and look at from the finance perspective, it's worth really familiarising yourself with the Statement of Financial Entitlement, also known as the SFE, because it really sets out the reimbursements that practices are entitled to claim for. So this has been static for many years until last year, where there was an uplift for locum reimbursement by 3.5%. But interestingly, for immunisations, there has been no increase or change in the item of service for vaccination programmes such as COVID and influenza, which remains at £10.06. One can reflect that back and say, well, it's almost as if the government is trying to disincentivise us from undertaking them. You can think and share your reflections on what your thoughts are on that, but that's worth really looking into. And then the other financial matters I've mentioned, that prior to the DDRB reporting, the estimated staff uplift was 2.5%. But 3.5% has been accepted by the government, which is positive. The out-of-hours deduction remains the same, of global sum of 4.7%, and the actual figure is £6.11. got a couple more slides on here. Other financial matters, ARRS GP has been uplifted by 3.5%. For other staff, it's been uplifted by 3.3%, matching the Agenda for Change uplift. The enhanced access element of the PCNDES has also been uplifted by 3.5%, and there are an additional 18 QOF points worth £25 million, which will be showcased after it might be on finance. So what's remained unchanged? Some things do remain unchanged. CQC fees continue to be reimbursed at 100%, and the learning disabilities health check at £140 a patient, and the network participation also does remain unchanged as well. So this is where we leave our brief run through the new contract, but in summary, you've just got a real whiz through there of the contract finances for 26-27, the headline contract numbers, looking at inflation, transfers, losses, and global sum. And the reflections, in essence, is that funding is effectively static. Workload is rising faster than the resource, which has been demonstrated by what we've just shared thus far. PCNDES has lost a big chunk of funding, but it's been given back to us with strings attached. And if there's one thing of the contract you should familiarise yourself with, it most certainly is the statement of financial entitlements. Over to Elliot.
Thanks very much, Asia. And hello, everyone. So again, for those of you that don't know me, I'm Elliot Singer, GP partner in Malvern Forest, East London, but Deputy CEO of Londonwide LMCs. And I've been asked to talk about QOF and the changes to QOF that's been occurring over the past year. And now, if you've ever heard me speak about QOF before, you'll know a little bugbear of mine, which I'm going to come on to in a moment. But as Asia said, there's 25 million of so-called new money that's gone into this, equate to 18 points. And there's been lots of movement. So there's 95 points that have been retired from one indicator and reassigned to another. And now for the bugbear. The headline is that the QOF point value has increased to £227.95. But this isn't actually quite right, because the only thing that's increased is the contractor population index. And this is the average number of patients in a practice that they say, and that's what they base it on. So it's gone up to 10,295 patients this year. So actually, if we standardise QOF per 1,000 patients, it is, and always has been since 2004, £22.14 per 1,000 patients. It's never changed. And actually, if we look at ASIA's inflation and do the calculator for that, the equivalent of £22.14 in 2004 is around about £40 mark now. So that's how little in real terms, rather, QOF is worth compared to it was 20 odd years ago. So always remember that when we see these headlines about the rising QOF. This chart, when we share this with you, this is quite useful to have, and it's just considering the way things have been moved across and reallocated from one, and a little table and seeing the new ones. But we're going to break this down into a little bit more detail now. So one of the key new ones is about the obesity work, and we've got two indicators on this. First of all, and this is really important, it's about referral to weight management within 90 days of anyone with a BMI recorded as obese. And then the second point to this is the shared decision making are offered, including the offer of NICE approved medications for management in primary care. Now, this does not, and we're seeking clarity on this at a national level, because some areas are interpreting that as we don't need to do tier 2 services anymore, and the GPs can just be responsible for prescribing all the medication. Please remember, QOF is there to as a performance reward system. It is not there to fund the work required. So a little bit like if somebody else does a blood pressure monitor and we record that in the notes, that still counts towards our points. So the interpretation of this means that GPs need to be the ones prescribing and actively managing it. We are actively challenging at the moment. But this is a workload. This is definitely a workload in there. And one of the things that I'm most certainly noticing in my own practice is patients have heard about this and expect that we're going to be able to prescribe, and not appreciating the NICE guidance and the restrictions on it with the 5 comorbidities and needing at least 4 of those. So we need to think about how we communicate this to patients. hopefully prior to them using a consultation for us to explain it, so that they're not coming in with unrealistic expectations during that consultation. So that's the obesity one. The next big change is regarding blood pressure. And the blood pressure indicators, there's a couple that have been reallocated. And essentially, this is now about the sort of 79 and unders, 80s and overs, and the different blood pressure control in them. But key to this is that this is people without frailty. So another take-home message here is that actually get your frailty coding right. So one of the early things you need to be doing in the QOF year is actually looking at those patients in these cohorts and make sure if they are frail, they are coded as such. And if they're not coded as such, because if not, that's going to have an impact on all this data and all this work that you try and do. QOF has, heart failure and diabetes have subtly changed in that it's the heart failure has really caught up with the general practice really and good quality practice, that we talk about these 4 pillars of therapy. So for the non-clinicians that are listening at the moment, this relates to the patients being on ACE inhibitors, beta blockers, mineralocortical receptor antagonists, and SGLT2 inhibitors. So part of this work is actually making sure that everybody in the team understands that you're doing the searches, you're identifying when they're not, and if appropriate, then you are having the conversation with them to put them on it. Diabetes is more moving from other codes into the 8 care processes, because we've been doing these things really. This is the BMI, blood pressure, HbA1c, cholesterol measurement, smoking, foot checks, the ACR, the urine ACR, and making sure we do the EGFR. So hopefully that's just really rebadging it into here rather than anything actually new. There's been quite a lot of changes to the vaccines, and I'm going to cover that in a separate section shortly. But this is important, this bit now. This is about the personalised care adjustment, and this is new for this year. So we're moving away from exceptionally reporting. It replaces this and is subtly different, because actually within this, rather than the exceptionally reporting, which takes them out of the register and counting, this is for the particular indicators. So somebody may be excluded, if you like, from a particular indicator, but not from the actual overall disease register. But equally, even if you've excluded them and then this is achieved, it will still count towards that work. And there's, broadly speaking, these 6 reasons for why we can exclude them. If the service is not available, if for one reason or other the patient is clinically unsuitable, the patient decides not to have it. The non-responders are subtly changed, because if they, you need to be trying to invite them on 2 occasions now, except for cervical screening, which is for 3 occasions. You can then call them a non-responder. And there's, it's worth looking at the business rules on this, because if it's a newly diagnosis, you have certain timelines of which you can actually say, well, we haven't had time to do that. Equally with the new patients as well. They can be excluded from that if they haven't registered within the practice within sufficient time. Okay, just moving on for that. Good. And I know QOF has been around a long time, but it's always worthwhile thinking about your approach to QOF and to think of it as a little bit of a QI project and how you can do it better. So what I'm going to ask people now to do, and if Andre can open up the first of the polls for me, because I just want to ask you a really simple question. How easy is it for you to achieve your QOF points? So I'm hopeful, Andre, you're able to do that. There we go. Wonderful. So nice simple question. How easy is it for you to achieve your QOF points doing whatever system you use? So difficult, quite difficult, manageable, or quite easy? And we will give people a few more seconds. Andre, when we've had a reasonable response, if you can just close that so we can see the results on that one. Hopefully it can be closed now. There we go. So most people find it manageable, but actually over a third of you are saying it's still quite difficult or difficult. Okay. And now there's one more question I've got to ask you before I talk about it a bit more, about the way in which you do it. So bearing that in mind, and if you can open this one, do you just do opportunistic work? Do you do it in the end of Q4? Do you spread it over the course of the year? Or do you absorb it in normal clinics? There may be other ways as well. I appreciate that. And again, just literally a few seconds just to briefly answer that. And then Andre, when you're ready. Okay. So interesting that, you know, almost 3/4 of people sort of do it over the course of a year now, but still, you know, over a fifth of you are sort of doing that thing. And I used to drive me insane, that end of year rush. It's really difficult to do. So as I said, is that what I would suggest to all of you, even if you think it's easy and really good, is take a QI approach to this. And there is more information available on this, but sort of thinking about the workload, thinking about using your teams, and especially in being proactive in when somebody's invited. Have they had the blood test forms in advance, the urine test forms? Have they been sent the asthma control test? You can use, you know, we use AccuRx to do that type of work on it, so that you really try and absorb this. So I really would suggest that you try and think of this in advance, you divide it up, and actually, if you can spread it over the year, it's much more manageable than having to do the end of year. And also, if you do it in the end of year, you don't have an opportunity to make a change and then retest that person to see if they've got into range. So really think about that. And so use this as a bit of a reset. As I said, the clinical pathways for the obesity are really important. That's new this year. Thinking about don't work on the retired indicators. You know, we've all got enough work to do without doing that. Look at your frailty indexes, upskilling the staff, both for the 4 pillars and the 8 care processes. We're going to talk about increasing childhood vaccine uptake and the personal care adjustment. There's just going to leave you with those few tips. I'm not sure whether or not there's any questions, Vanessa or Darren, that have been posted that anybody wants me to try and ask just before I move on to vaccines.
Darren's doing a great job answering the questions as they come up. We do have one from Emma, who says currently there's no local pathway for OB005 referral in NEL. They've set up a primary care service for 25-26, but have paused this since April, and no news on replacement. Do we just wait and at the end of the year code them all as no service available?
So thanks, Emma. And as you know, I'm very much aware of this, being a North East London GP. I think at the moment we have to sit back and wait, because as I said before, this is not for us to be doing this work. This is to make sure the systems are in place. We need to be doing safe care. So at the moment, it's maintaining the pressure on the ICS, which I know you are doing, in trying to address this.
Thank you. I think all other questions have been picked up on the chat.
In that case,
if I might just say, thank you, Vanessa. So we are trying to answer them in the chat wherever possible. So can I just gently remind people, we're not all familiar, I know, with the Q&A section, but there's a speech bubble if you click on if you want to ask a new question, and then we'll try and answer them in the chat, or we'll get them to Elliot and the team at the end of each section. Thank you.
Thank you. Right. Okay, as always, I'm running ridiculously over, but I am going to move on to vaccines, because it's an important area. And there's been a really important change this year that's going to benefit, I think, London GP practices. London has notoriously had problems because of our population and a migrant population of achieving absolute targets. What they're doing this year is they're moving to actually providing, if you get an improvement from your baseline of at least 5%, that you can earn some QOF points on this. So this is a real opportunity for us. So I'd encourage people early on to look at this. Outside the childhood IMS, there has been a change in the SFE about the RSV vaccine, and that this is not just all patients aged 75 and above, but those below the age of 75 in care homes. And it's in the MMR now includes the varicella vaccine in it as well, and that's been updated to represent that. The PCN one, we've got Vicky talking a little bit later on about PCNs, but there is, we've got to make sure there's access to both the seasonal and routine immunisations, as well as better collaborative arrangements were enabled. So I'm now going to just talk a little bit about thinking about the vaccine. We all know there's some barriers to uptake that we can't do anything about, those socio-economic factors on the left in that box. But there are things we can do about the way in which we get people to access healthcare and the systems we have in place, and thinking about how friendly our systems are. Recommend this document by the RCPCH on looking at vaccine uptake in the UK. It was from last year, and it's got some really helpful suggestions in it, very much around thinking about your reminders, your recall systems, whether or not you do opportunistic vaccination. You know, if someone's in and you're talking to the, you know, the parent with that young child there, and you've got a nurse or someone that can vaccinate available, while they're there, can you ask the person to do it? Do they have the capacity to do that? Flexible access. I heard recently about one practice that had a part-time nurse on a Monday afternoon and wasn't hitting their targets. Well, that Monday afternoon's during school hours. It meant people taking out from work, from school, etc. It means it's really difficult for people to access it. So think about where we've got the access there. The extended access appointments, can you utilise those? Outreach clinics. We've had some great things with people going into local community centres, into various sort of even religious centres and things like that, to actually do the reach out and vaccinate. And as I said, the one-stop clinics, if you do have a health visitor in your practice, in your health centre, can you coordinate so that you put on a vaccine clinic alongside the work they do? And as so much of what we do in general practice is about relationship-based medicine and the personalised engagement. So actually, when you build a relationship with the parent and that child, then actually just softly, you know, reminding them about the benefits of vaccinations and why you want to do that. Because at the end of the day, you know, yes, there's payment associated for this, but we're doing it for a really important reason. And the primary prevention here stops morbidity and mortality. So apologies for racing through that a little bit too much, but as I said, it's a real opportunity to improve from our baselines, and I really would recommend looking at the RCPCH document, because it's got some really helpful tips on things you may wish to consider to put into your practice to help you along and improve your access. So if there's any questions on vaccination, happy to take them. If not, I will hand over to my colleague, Vicky Furlier.
I can't see anything on vax, Elliot. There's a few on cough and weight management and others. I'm not quite sure if you'd be picking those up now or later.
We'll pick those up later then, Vicky.
Oh,
so if you want to
lovely. Yeah,
take
sure.
control, thank you.
Thank you very much, Elliot. Thank you. Hi everyone, my name is Vicky Furlier. I am the Director of GP Support. We have a centralised team that supports and gives bespoke confidential advice to individual doctors or practicing difficulty, working across all 5 ICB areas, and I have been asked to talk about the PCN-DES today. So as you all know, the documentation for the PCN-DES was issued back in March, on the 26th of March. So it's one element of the contract along with the SFE, which is still yet to be amended, that we have more information on. I just thought to cover just for 1 minute some of the basics around the DES for any of you that might be new to general practice or may not be familiar with this. So the DES, the PCN-DES, has been varied into core contracts. This means that it's an extension of your GMS, PMS or APMS contract, and the rules around the contract will apply to the DES as well. If your practice has previously participated in the DES, which means that you're a core member practice of a PCN, it's an automatic rollover. You just need to confirm this on CQRS, and when the contract variation is issued, which we haven't seen yet, just sign that. The contract variation will become legally binding anyway. It's a statutory instrument within 14 days of issuing, so whether you sign it or not, it will apply anyway. This is a question we get quite regularly. There is a formal opt-out window or a PCN changes notification window, which is by the end of this month, which is effectively the end of this week, or within 30 calendar days of the DES variation being published. I'm saying there is commission flexibility on this because there is. So in London, across all the different ICB areas, commissioners are aware that there would be changes being requested sort of mid-year, halfway through the year, or any point really. So they haven't really been that strict on maintaining that window. So they have been working with practice PCNs and us when necessary to facilitate those changes at different points through the year really, which is very helpful. So all other requirements in terms of your eligibility and participation remain unchanged. And with the in the documentation for the DES, there is a new mandatory network agreement. So I'll mention that again later. It's really important that you make sure that your network agreement is up to date based on the new requirements of the DES. Right. Moving on to the changes, so your PCN network area needs to align with neighbourhood boundaries as these will be defined by your local commissioners and the local authority. You're expected as PCNs to work collaboratively with your local commissioners to achieve this alignment. The message from NHS England has been on this that they expect minimum disruption to existing PCNs. However, we're already getting quite a lot of concerns from practices and PCNs and generally from the profession around potential disruption here, particularly of PCNs who might be sitting literally on the border of different neighbourhood boundaries and what this might look like in terms of delivery of services at neighbourhood level. All of this detail we haven't got yet. Hopefully things will become clearer when we see the detail of the contract. The other change is that obviously PCNs and member practices will need to participate in the GP staff survey as practices to a practice level at the moment. Moving on to the biggest change of this year, which has already been alluded to by Elliot and Asia. £292 million of the capacity and access funding payment will be removed from PCN budgets. It will move into practice funding under what's called a practice level GP reimbursement scheme. I've already seen a question in the chat about this, and we've started receiving questions from practice already. The intention behind this is obviously to expand the recruitment of additional doctors or fund additional service sessions from existing doctors who work in practices in order to support same-day access for the clinically urgent patients. There are concerns around this, as the person on the chat has put. Do we have any details on this? No, we do not yet. We don't know what the eligibility criteria will be. We don't know what the claims process will be. We don't know what the mechanics of this will be. So please bear with us until more information is revealed as we see the contract documentation. The concerns around the destabilization of PCNs are there. We are getting them quite regularly, because at the end of the day, when you have funding, the funding goes to staff, the staff deliver services, and all of this comes together at PCN level at the moment. So it's not actually quite clear how all of this is going to work when the funding moves to practice level. So as I said, please bear with us until we have more information on this coming from the centre. Moving on, there was a restriction previously on the GPs being fresh out of training, within 2 years out of training. This now restriction has been removed. This enables you to be more flexible and expand the workforce with more experienced GPs that are no longer just within 2 years out of training. The changes of the funding side of things are aligning with this to enable maximum reimbursement to be claimed for GPs via your Rs funding, which is increased now to the top of the salary pay range for GPs. Plus on costs, the numbers are there for your reference, and also the London, the addition for London. So also in terms of the flexibility, the new DES enables PCNs to recruit a broader range of Rs roles that are non-direct patient, that relate to non-direct patient care. Obviously, this will have to be agreed with your local commissioners. And one rule is that they have to be different to those staff already working in your core practices, your core member practices, or in other existing Rs roles. Again, how this is going to work on the ground, we're not quite sure. But in terms of the intention behind it, it's a positive thing. Other changes. So it's a core expectation in this year's DES that there will be continuity of care. And that's why the PCNs are now required to use risk stratification tools to identify and prioritize patient cohorts in terms of their continuity of care. There is also a requirement for an identification of your eligible care home residents for vaccination arrangements, so that they can be offered both seasonal and routine vaccinations. You don't need to do this at PCN level. You can subcontract or engage with another organization to do this on your behalf. But as long as you have the vaccination arrangements in place, you'll be okay in terms of complying with this particular requirement. Adult flu and COVID vaccinations are now included in the new network agreement, the new mandatory network agreement. This means that previously you had to work in a collaborative group under a collaboration agreement. That's no longer necessary. You can work with each other within your PCNs to deliver these vaccinations. It's an enhanced service now under your collaborative arrangements within your PCN DES and within your PCNs. Also, there is a requirement to improve cancer referrals, early diagnosis and screening update across the different types of cancer, as you can see on the slide. Here I've just put for your reference, I'm not going to go through all of this, a sort of a summary table of all the funding changes from core funding to enhanced access care home premium, which is of course per bed and not per patient. And also, as we've discussed, the removal of the capacity and access payment from PCN budgets moving into practice level. And as you can see, the IAF funding, so Investment Impact Fund, remains at the same value as last year. So this is what we've covered so far. We've just looked at the very high level of the contract DES specification for this year. Obviously, it wasn't an exhaustive list. It was just the highlights and the main changes, and also a quick look at the funding for this year. That's what I decided to kind of put on the top tips slide, because it's really important that you do that. So our staff is going to be huge. The change of the funding arrangements are going to be very important. So start by reviewing your Rs budget, obviously minus the capacity and access payment funding, to look at what your needs are, how you can transfer staff from the Rs, from PCN level to practice level, and also how you can recruit at practice level. As I said, the mechanics of this and the detail of this is yet to be sort of disclosed, if you like, revealed, when we get the documentation for the new contract. Review your enhanced access arrangements and your same-day access delivery under those changes that are going to be quite significant, and look at your cancer screening. One more slide. I haven't actually spoken about this much because it wasn't the purpose of this, but we do see quite a lot of PCNs in difficulty or having disputes. So I was asked to just put some high-level top tips in terms of how you manage those, or how you even avoid them if you can. I made reference earlier about the importance of updating your network agreement. We see quite a few PCNs haven't even looked at their network agreement after it was put together back in 2019 when the PCNs came into being. Don't do that. That's a big issue with PCNs that have got difficulties and they've got disputes internally. Please review regularly, and now that we have a new mandated network agreement, please make sure that your one reflects the changes that have come in. Use subcontracting agreements where appropriate. What we mean by that is that whether you are subcontracting services under the DES or outside of the DES, and we know quite a few areas in London have got additional contracts at practice level, for delivery at practice level, where PCNs might be subcontracting a federation, community service, or any other provider. Quite a few times we see them not having subcontracting agreements in place. That is an oversight, significant oversight, because it doesn't give you a framework within which you can actually monitor the delivery of the contract and hold your subcontractees accountable. In terms of governance, it's very important. When we're talking about governance, we're talking about simple things like how you run your meetings, how you make decisions, how you what your voting structures look like, what your financial arrangements are like, what your financial reporting arrangements are like. The other thing that keeps coming up is difficulties around managing staff, employing staff, our staff, and what this relates to is, for example, if you have an issue with an Rs member of staff who is working in practice A and a complaint comes in, who manages that? if that particular practice does not hold the employment contract for that member of staff, it's held either centrally within the PCN or it's been subcontracted to, say, a federation, or all these policies need to line up and your processes need to line up. Otherwise, it's quite difficult to manage those situations. And if you have difficulties internally, engage with each other, talk to your practices, make sure decisions are inclusive and there is constant communication and early addressing of those issues. And if necessary, seek external support as well. I think that's all I had to cover today. So, Elliot, do you want to take over?
Thanks very much, Vicky. I think actually Lisa's taking
Lisa
control of
next.
this
Sorry,
one.
yeah, okay. Lovely, thank you.
It's a double act, Vicky, but Elliot's quite right. I'm the one that's taken control of the screen. Okay, I don't know if there were any questions from the last section that we just want to call Vicky back for. Any questions to pull out from the chat?
Questions on the chat at the moment, on the questions and answers.
Fantastic. Thank you very much. Okay, so we're going to move on to discuss some areas of concern that we know were fed back to us before the webinar and that we're hearing from the ground. One of them is around access. So Elliot, I'm going to ask you to help us understand this a little bit more. So the contract letter states that anything that's clinically considered urgent must be dealt with on the same day. But what does that actually mean? Because we're all very concerned, aren't we, about how we're going to manage this when we have finite capacity and we can't turn off the online consultations or ask people to call back. What are your views? What can you tell us on this?
Thanks very much, Lisa, and you're quite right. It's a huge concern for all of us in practice. And just on this links into the safe practice, and some people may be aware, but you and I did a little bit of a webinar on this about 18 months ago, which can still be viewed on the Londonwide LMCs website, and I would recommend people review that as well. But thinking about this year, so, you know, as GPs, we have a duty to provide safe care, and also to look after our own staff well-being, and having uncapped demand just feels that it's counterintuitive to that type of principle. So we have to, when we're thinking about this, we have to think about what does actually deal with or dealt with on the same day mean, because that's what the contract letter is saying. So we come back to the old thing about words means what words say. And so to deal with it on the same day is the need for me to make a clinical assessment on the basis of the information I have. So this may be from the online consultation, it may have been received by the call that the person put through in the message from the reception team. It could be from somebody else that you've got this information from. And on the basis of that information, I then, if I've deemed it urgent, I need to take action. And that doesn't mean a face-to-face consultation with the person. And actually, if I deem that that person does need a face-to-face, but I don't have the capacity, then I would need to refer them or direct them onto another service. And people have been challenging whether or not this is right or not. But actually, when we look at the GMS regulations, which is what we always need to come back to, it states it is. And for those of you that like detail, well, look up Schedule 3, Paragraph 4, Clause 2C, and you'll find it. And what that actually says is that we need to invite the patient to make use of or direct the patient towards appropriate services which are available to the patient, including services which the patient may access themselves. So if you're challenged on that, that's where it comes from. It's in the regulations. But this is after adequate triage. So another important thing of that is that the little d in that same clause, which says that if you haven't got enough information, you can go back to the patient and ask for more information. So if you've got, you know, what I frequently see an online consultation that just says abdo pain or something like that, I can't make an assessment on that. So it's perfectly reasonable to go back, get the information you need, and then determine whether or not that is urgent for the same day. And if it is, then if you can see them, if you've got capacity, see them, but if not, advise the patient appropriately. What we can't do is just have automated processes redirecting them to. So in the past, in my own practice, we had a telephone message that said, we're at capacity. If you think it's urgent, please contact 111. We can't do that sort of thing anymore, but it doesn't stop us redirecting. So Lisa, I hope people will find that helpful. Clearly, we're waiting for more information on all of this. So that's looked at that, but I'm going to now ask you a question, because actually we've had a lot of queries about the mandatory use of advice and guidance or single point of access, and it seems to just constantly be changing, and it's really hard to actually understand what's going on. So are you able to provide any clarity, thinking sort of from your regional viewpoint or national viewpoint?
Yes, thanks, Elliot. It's true, isn't it? We have had shifting national policy and acronyms regarding this, from advice and guidance to advice and refer, and now to single point of access, SPOA. This does seem to be moving quickly, but the national messaging seems to have softened. So we know GPs have many concerns about this, including unsafe rejections and deflections of referrals, workload and increased clinical risk being pushed into general practice, and loss of autonomy of and respect for GP expertise. In their publication last week, NHS England tell us that the SPOA isn't about rejecting referrals and there are no deflection targets. Previously, there had been lots of talk around 25%. And they also state that thresholds haven't changed and that GP judgment remains central. But capacity and financial pressures do and will affect what happens to our patients. We all know the reality will be local variation and inconsistency, both between and within hospitals, and there are a plethora of different complex reasons for that. But this is where LMCs and Londonwide LMCs have a critical role in mitigating the risks. We will ensure GP voices shape how these pathways actually function. We will be actively representing GPs in the co-design of these pathways at both trust and London levels. In fact, LMCs already work with each trust through regular interface meeting where specific pathway issues are challenged, and in some areas of London, for some specialties, we already have some good experiences of working with our secondary care colleagues on these types of programmes. The London-wide LMCs work at the pan-London level in interface meetings and other regional forums will continue, and this is where we escalate themes, we share good practice, we call out where systems are unsafe or inequitable. We will continue to challenge inappropriate workload and risk transfer. We will continue to push back where thresholds are creeping up in practice, and we will hold systems to account where patient access is being compromised. And where issues are nationally driven and can't be resolved at the London level, we will still act. We will advocate for GPs so GPs can deliver safe, effective care. And we do that through engaging with MPs, national bodies, key partners and allies, ensuring that the impacts are properly understood and challenged. But at the same time, there are opportunities here if this is done properly.
Opportunities, you feel, really?
Yeah, I mean, I can't tell you how realistic this is in the current NHS context. But done well, a SPOA could mean that you don't have to second guess the exact service to refer to from a list which is out of date, only to have the referral bounce back. And potentially it could enable true consultant clinical triage with more nuanced weights rather than the choices we faced, which can feel like urgent or wait for an unknown period of months to years. It should also give us much better data on true demand for specialist services. And that matters, because putting that alongside the wider drive to move care close to the community, this potentially could create an opportunity to properly commission tier 2 services at scale in the community, for example, led by GPRs. And it could help us to rebuild some of those models similar to the gypsy services many of us remember from the noughties before local funding was withdrawn. And we had lots of positive experiences of those services, of having a community-based service, having better relationships where we could have conversations about patients. And it did, in some areas, bring us much closer, that interface between primary and secondary care, much closer and became much more collaborative. It could go a little way into supporting that type of more meaningful collaboration, rather than the very fragmented transactional one-way interactions that we have now. But none of that will happen by default. In addition to political will, it will require active design, challenge and ongoing engagement. And that's where LMCs will also need to focus their efforts. So we do want and need GPs to keep feeding back their experiences as this progresses, good and bad, so that we can represent and advocate effectively at all levels. We need to know what's going on so that we can raise it, challenge it, and work to fix it across London. So I hope that helps a little bit around advice and guidance and the SPOA element. Elliot, I've got a final question for you though.
Yep.
There seems to be a lot coming out about the need to code all appointments and that this is changing. Can you provide some clarity on this?
I will try, that's for sure. So for some time now, practices have needed to be aware about how they code their appointments. It was brought in 2021 with the PCN-DES, and at the time we did produce a guide which is on the website and will be updated taking into account this year's changes. So the key change about this year is about the monitoring. So you need to know what's being monitored. So they're monitoring the call waiting times, that's throughout core hours, but specifically from 8 AM to 10 AM. They're looking at the percentage of clinically urgent patients seen on the same day and the percentage of non-clinically urgent patients seen within 7 and 14 days. Of course, this is all retrospective monitoring of the data, and I know that query came up. But it's the way in which they're calculating this which is key, because they can't actually just directly go, that's the percentage clinically urgent seen on the same day. So what they're having to look at is look at those appointments that are coded as general consultation acute, and then look at the time from booking. So by looking at how far in advance they're booked, so it's on the same day, that's how they're getting that data. And this is important for people to understand, because that same day is there's a percentage of the time ones that are coded as general consultation acute. So what that means for practices is that if they aren't correctly using the general acute consultation coding, it's not going to be picked up by the national data. So if you think about those appointments that sometimes they were advanced booking but weren't used and then suddenly use them from the day, if you don't change that type of consultation, it's not going to be put up for these. So you're going to miss those type of things. So when you are changing the use of a consultation from a pre-bookable to an on the day or vice versa, you need to adjust this. So equally with the 7 and 14 day appointments, which is the other thing they're looking at, what their category they're looking at is general consultation routine. So again, you need to make sure any of those booked at 7 and 14 day in advance are coded as general consultation routine, and the time from booking is the other thing they're looking at in there. Now, the problem with this is that a lot of us are doing digital triage, and what we need to be careful to do that if we are triaging that doesn't actually result in any contact with the patient, be that electronically, by the phone or in person, then we shouldn't be recording that as a consultation. And I know some practices that have fallen into difficulty because of that. We also need to recognise there is an awful lot of work that they are not capturing. So, all the nurse appointments do with long-term conditions and all that sort of thing, the clinical admin work, the MDT one, the home visits, that's not being captured. And I think the reason for that is a lot of the motivation behind this is the clinical headline about we are getting rid of the 8 AM scramble. So we need to bear that in mind and really be carefully looking at how we're coding these. And know and understand your data. So you can look at the GPAD website directly. That it's a month in arrears. It's actually slightly longer, but there's some other really helpful resources that you can look at to actually help you with that. One of which I personally have been using recently is CAIP.app, APP, and that gives a lovely breakdown of appointment, telephone calls, including the missed calls, that type of thing, your online appointments, so your online consultation and all your appointments as well. So utilise the digital teams that you've got to help you, but the first starting point of all of this must be that you go back and just double check that you're using the right codes for this, because you know what's being monitored. So I hope that's helpful, and I hope that clarifies some of the point, Lisa.
Thanks very much. So we're moving on to our close now. Hopefully we've been able to keep up with most of the questions in the chat, or we've answered them as we've been going along. Elliot mentioned a video and some other resources that we have available. They're all aiming to help you deliver self-care despite the self-care is very important, but this is related to safe care despite the pressures. Please do have a look at our website. There are a plethora of different resources to help you. As we close, we know this is a tough moment for general practice. We see the pressure you and your teams are under and the impact this is having day to day, and for the GPs in our teams, we experience this too. Today's webinar is just the start of our support for new contract implementation. Our commitment is straightforward: to stand alongside you. We will represent you, we will support you, and we will advocate for you where issues are nationally driven and can't be resolved locally. Following today, you'll receive our slides and an FAQ, supporting resources, including our practice survival pack, ongoing guidance and support, and further updates as more information becomes available. We may not control the national contract, but we see what's happening on the ground. We understand the pressures, and we will continue to act on your behalf. Please stay in touch with us, either through your LMC or directly with Londonwide LMCs, because what you tell us is really important. It shapes our priorities. It shapes how we act on your behalf. Let us know what's working. Let us know what's not. Let us know if there are any additional resources, be it further webinars on particular issues, guidance or tools that you think would be helpful. And also, please do give feedback on this webinar. Please do complete our feedback form. It's in the QR code on the slide. We are really keen to learn from this and to do more of these things so that we can engage and support you. And also, please do remember that none of you, none of our GPs, none of our teams, we're not superhuman. And I slipped up earlier with self-care, but that was a Freudian slip. It is really, really important that we are able to look after ourselves and to look after each other. And we do have a professional support platform that some people may find helpful. Finally, a sincere thank you to everyone who's made today possible, especially Elliot, my Deputy CEO extraordinaire. But there have been lots of people behind the scenes, either preparing content, people managing the chats, managing the questions, and supporting with the presentation, and poor Andre, who's had to guide us all through the technical side of things. So thank you to everyone. And importantly, thank you to you all for everything you do for your patients and your communities under real pressure. You're doing an absolutely amazing job. As I said, this webinar marks the start of ongoing engagement as we move forward together. Please do keep in touch with us, and thank you for joining us.